Hopefully folks can see my screen now. These are my disclosures. The National Marrow Donor Program works with many companies and other organizations dedicated to making progress in this field. So the objectives of my talk today are to outline efforts that the National Marrow Donor Program and the CIBMTR and other partners have undertaken to improve outcomes of stem cell transplantation, to describe recent efforts to address disparities in access to transplant by our organization as well as others, and also in a 10-minute talk, recognize that you're going to leave a lot of people out and we really can't cover anything. My focus will be on a research evaluating the prevention of graft versus host disease and improving access to transplantation for all who may benefit, because as you've heard from many of the speakers today, the impact that graft versus host disease has on quality of life and disability. I won't focus on efforts to prevent disease relapse, just recognize that this is also an important area of research, particularly in adult transplantation. So this slide is just a kind of level set. So at the inception of the National Marrow Donor Program back in 1987, the expectation if you had acute leukemia and first remission and had transplant using a volunteer unrelated donor was of 1-year survival at about a little under 40%. And now the expectation in 2021 is overall survival approaching 80% at 1 year. So this represents substantial progress, and I think is at least in part and in large measure due to knowledge generated from clinical research. This slide is this is from a recent review in the Journal of Clinical Oncology, is just to remind us of the variety of ways that we can try to provide a curative allogeneic transplant for all patients, as well as the various means to prevent complications. I will focus on graft source and donor type, as well as means to prevent graft versus host disease. So again, talking about prevention of graft versus host disease, I think to be widely applicable and really represent progress, the new approaches have to increase access to transplant by mitigating the impact of HLA mismatching. You've heard a little bit about that from earlier speakers. It has to be less toxic and, again, not contribute to late toxicity. And here we can think of particularly the kidney toxicity associated with the calcineurin inhibitors, cyclosporin and tacrolimus. There should be less influence on immune reconstitution. You heard from Dr. Perales about immune reconstitution, response to vaccination. And again, I think new approaches should be able to predict who is at greatest risk of graft versus host disease, as opposed to taking a one-size-fits-all approach. I think you can look really broadly at the general approaches to prevent graft versus host disease as pharmacological and physical, where we manipulate the graft. And you know, you heard from Dr. Applebaum, where now more than 50 years into the modern era of transplantation, and yet I think it's remarkable that not a single drug is yet FDA approved for the prevention of graft versus host disease. There are some for treatment, but not for prevention. And we do have one device that's been approved for GVHD prophylaxis on a humanitarian device exemption. But I'm going to talk about two drugs, post-transplant cyclophosphamide and a drug that blocks CD28 of the second signal called Abatacept, because I think that they represent real advances. So you've heard a little bit about post-transplant cyclophosphamide from some of the other speakers. These are data that was presented at a plenary session at ASH a couple of years ago from the Dutch HOVON group, comparing post-transplant cyclophosphamide to cyclosporin-based GVHD prophylaxis in a randomized trial that involved both matched related and unrelated donors using peripheral blood, and was associated with better prevention of graft versus host disease, and so GVHD free, relapse-free survival was improved with post-transplant cyclophosphamide. Building on this, the NIH-supported blood and marrow transplant clinical trials network undertook the so-called Progress 2 trial that you heard a little bit about from Dr. Perales, which was, again, trying to build on this idea of getting away from calcineurin inhibitors and all the long-term toxicities that these medications have, and to try to effectively prevent graft versus host disease with other means. And so this trial, which actually was completed several years ago and was reported last year at ASH, and manuscript is in press, had a primary endpoint of prevention of chronic GVHD relapse-free survival, comparing post-transplant cyclophosphamide as well as T-cell depletion using the available CD34 selection methodology in patients who are well enough to receive a more stringent myeloablative conditioning regimen. And what we found was that, as you heard from Dr. Perales, there was no difference in the chronic GVHD-free, relapse-free survival. There was actually less GVHD in the T-cell depletion arm, but more risk of treatment-related mortality due to higher infections. However, the PTCy arm was interesting. It did not include calcineurin inhibitors, and results were similar to tacrolimus methotrexate, so suggesting that this might be an alternative, particularly for patients who might go into transplant with some renal toxicity. The CTN is also performing and has just completed accrual to the so-called Progress 3 trial. This is, again, looking at GVHD-free, relapse-free survival in older patients who are less likely to receive a myeloablative conditioning regimen and are better candidates for a reduced intensity conditioning regimen. This trial completed accrual in June of 2021 and is in follow-up, and will hopefully tell us whether post-transplant cyclophosphamide-based GVHD prophylaxis in combination with tacrolimus and mycophenolate mofetil will represent an advance over standard of care. But I show you this slide. This is data from the CIBMTR activity report from U.S. transplant centers, just showing you that in addition to the haploidentical related donors, you can see this just in a short period of time, the increased use of post-transplant cyclophosphamide in the matched sibling and matched unrelated donor setting, as well as even in mismatched unrelated donors. So people have already jumped on board and are making the change. And during the pandemic, the data suggests that about 35 to 40% of recipients of matched unrelated donor transplants are receiving post-transplant cyclophosphamide. So now to talk about a little bit about access to transplantation, these are data from a seminal paper that was published by the NMDP and CIBMTR back now almost 15 years ago, demonstrating that for each degree of HLA mismatch, you have roughly a 10% decrease in survival for each of those alleles or antigens that are mismatched. Now, looking at real-world data that are collected by the CIBMTR, you've heard again that we collect data on every single allogeneic transplant performed in the United States. We see here, compared to matched sibling transplants, that mismatched transplants, be it from an unrelated donor, cord blood, or a haploidentical related donor, are inferior in terms of overall survival relative to matched sibling and matched unrelated donor transplants. Why is this important? Well, we heard a little bit from Mary Horowitz about the disparity in access to transplants if all you can do is match transplants. And this is a table from the NMDP bioinformatics group showing you the ability to match with patients. So you see the blue bar on the left in African American and between 20 and 30% if all you could do is 8 of 8 transplants. But if you can go into the orange and even into the green, you can see that you can actually successfully transplant and have a donor available for up to 97% of African American patients. So the ability to overcome HLA barriers would really make a significant dent in the disparity in access to transplantation. And so given this, the National Marrow Donor Program sought to evaluate post-transplant cyclophosphamide in the mismatched unrelated donor setting. And I'm pleased to report to you that the outcomes were actually quite good. And the study was reported earlier this year in the Journal of Clinical Oncology. So this involved 80 patients who did not have a well-matched volunteer or related donor receive post-transplant cyclophosphamide-based GVHD prophylaxis, as well as a bone marrow graft. And interestingly, in most transplant clinical trials, roughly 10% of patients are racial or ethnic minorities. In this trial, 48% of the enrolled patients were racial or ethnic minorities, showing that we really were offering transplant for people who otherwise don't have access to a life-saving transplant. And the results were good. The 1-year overall survival was 76%. We had hoped it would be over 65%. So clearly, this seemed to have impact. And what we did is we looked at the outcomes in recipients of mismatched unrelated donor transplants and compared them with recipients of haploidentical related transplants, and we really didn't see any obvious differences, suggesting that mismatched unrelated donor transplantation using post-transplant cyclophosphamide would offer transplant option for patients who don't have a suitable alternative donor. So because of this, the National Marrow Donor Program has just kicked off and has activated a follow-on study. The prior study used only bone marrow as a donor graft source. So the current study that we are sponsoring, called the Access trial, is going to be looking at mobilized peripheral blood, which is easier for donors and easier to obtain, particularly during the pandemic. So in addition to evaluating this in 2 adult strata, we have also added a pediatric stratum as well, because the prior trial was limited to patients age 16 or older. So we're very enthusiastic and encouraged by these data and want to evaluate them in this new prospective study that we're sponsoring. I do want to switch gears and talk about another drug, Abatacept, because I think these data are important. I had just told you that there are no drugs yet FDA approved for prevention of acute graft versus host disease. And these are data from Dr. Leslie Keene and colleagues, initially at Emory University, now at Boston Children's Hospital, studying this drug, Abatacept or Orencia, which is approved for rheumatoid arthritis in the GVHD setting. And this was looked at both in the matched as well as the mismatched setting in 7 of 8 donors. And we actually, in addition to performing a control trial in the 8 of 8 match setting, compared outcomes in the 7 of 8 recipients to a pre-specified matched cohort from the CIBMTR. And as you can see here from these figures, there was really a striking decrement in the cumulative incidence of grade 3 to 4 and grade 2 to 4 acute GVHD in the recipients of Abatacept. I show you here actually that data, though these were not direct comparisons, suggesting that with the use of Abatacept, outcomes in recipients of 1 antigen or allele mismatched transplants approach those with 8 of 8 transplants using Abatacept, and perhaps were better than those with the standard of care. And on the basis of this, the FDA has recently accepted and granted priority review to a supplemental BLA for Abatacept to prevent graft versus host disease, with a PDUFA date later in December. So we may have the first drug FDA approved for the prevention of graft versus host disease. I'll just end with discussion of other strategies to prevent graft versus host disease and switch to graft manipulation. Now, T-cell depletion has been around as long as transplantation has been around, but we really have better tools now for actually manipulating and selecting the cells that we want. You heard recently that bulk T-cell depletion, while it is effective at preventing both acute and chronic graft versus host disease, is associated with prolonged immune reconstitution and infectious complications. So the CIBMTR and the National Marrow Donor Program is supporting a number of trials now evaluating T-cell depletion with more elegant means for actually removing the cells most likely to cause graft versus host disease while retaining the cells that actually cause the graft versus leukemia effect, as well as have antiviral and other important anti-infectious effects. And these are just showing a few of the trials led by Dr. Marie Bleakley at Fred Hutch, as well as trials performed by a company called Orca Bio, looking at graft manipulation, which we really think will potentially represent progress in the field. And there's a very interesting study by Orca Bio that has just entered phase 3, looking at manipulating the number of regulatory T cells in the graft, which can prevent graft versus host disease while retaining the graft versus leukemia effect.
Steve, I'm wondering if we can wrap up. Good. You're in your summary. Thank you.
In summary, encouraging data being generated that suggest access to transplantation may be greatly enhanced by innovative pharmacological and physical approaches to mitigate GVHD. And we may be on the cusp of the first FDA approval for GVHD prevention. Graft manipulation in particular seems to be gaining traction. And I think that improvements in access will increase opportunities for patients with serious non-malignant disorders and will allow us to focus more attention on preventing relapse. And at NMDP and CIBMTR, we view research as critical to making progress in transplantation and provide scientific input, infrastructure, and support for successful conduct. And again, this question has been posed by others, but as we make hematopoietic cell transplantation more accessible to an increasingly diverse set of patients, older patients, racially or ethnically diverse, will we encounter unique toxicities and disabilities that we have not previously observed or considered? So with that, I'll hand it back over to Alexis.